Welcome to the Shift Report, the podcast from MCentric and the MCentric Foundation. MCentric is the go-to information and resources hub designed exclusively for the emergency medicine community. We regularly host key leaders from the field who share their insights and experience. Our goal is to inform our listeners and to encourage you to use what you learn to improve your practice and improve yourself. To learn more, please visit us at mcentric.org. Today, we welcome Jason Hine. Dr. Hine practices in Southern Maine. He received his medical degree from Tufts University and trained in emergency medicine at Temple in Philadelphia. He's faced situations many emergency physicians face daily, the need to do a very important and potentially life-saving procedure that is not done frequently enough to maintain comfort or skill. He's trying to solve that problem with SimKit, which he will tell us about today. Welcome, Jason.
Thank you so much for having me.
Great. Thanks for taking the time to chat with us and join us on the Shift Report. First, you practice emergency medicine and had a pathway to it. Everybody's got a little bit different pathway. How did you end up in emergency medicine?
Yeah, I went into medical school not thinking emergency medicine, probably like many people. And I did sports in college. I think the natural inclination, if you're an athlete, then you maybe are going to be an orthopod, right? So that was what I was thinking at first. And then through my training with Tufts, I found, particularly my clinical years, the more I got to go through my rotations in third year, I liked them all. I liked psychiatry. I liked OB. I liked internal medicine, surgery. And I found that particularly in those longer rotations, if I started to be able to nail it down to about 15 minutes what my day was going to be like we're going to do rounds and then that will end at this time and then we'll do our orders and then we'll have lunch at this hour. That was not my favorite. There was a little bit of spontaneity or just lack of spontaneity in some of that. And so I decided to pursue emergency medicine and see sort of what that specialty was like. And it really resonated when I came into shift and didn't know what the day was going to be like, didn't know the patient acuity or census or any of that. That was exciting to me. And so that element, that sort of je ne sais quoi of just being able to go into work and not have everything nailed down to the minute or moment was really, really invigorating. And then the idea of, being the diagnostician, I think there's a lot of medicine now that has in some ways lost that people come in with their diagnosis already, that they are admitted with really thorough workups. And so the question of what is, what ailment does this patient have and trying to solve that riddle was really enticing. And then kind of pulling it all together. Like I said, I liked thinking cerebrally. I liked internal medicine. I liked getting my hands dirty and bloody with OB and surgery. And emergency medicine just really filled all of those needs for me as a clinician. And so that's how I ended up here.
Great, thanks. That's lots of people have a version of that, but everybody's got their own pathway. And thanks for sharing that with us. And I'm sure that had some influence on where you are now. So you're practicing, and I think I will reflect a situation that many of us see, where we all know a few people who seem to do every procedure, get the sickest patients, do the most procedures, and they just and they're slick at doing lots of things. That's not the average person in emergency medicine. And if you're practicing in a large center, you might have lots of specialists who do lots of things. You may not do a bunch of the things. If you're practicing in a medium size or a rural facility, you may be it. And I think based on what I know about SimKit, and I hope you tell us about it, you've probably faced those situations and felt the same level of discomfort that we've all felt when there's something that you knew how to do, you maybe haven't done it in 5 years, and maybe even the equipment has changed since you learned how to do it. And now you need to do it quickly, and you're it. So I presume that's a bit of your story, but tell us how you ended up with this idea of what became SimKit.
Yeah. Yeah, great question. And I think you're right. This has been a journey that we all have walked down a path we've all walked down in some capacity or another. And I really appreciated my training at Temple. I went from New England just slightly south to Philly, and I felt like it kind of cut my teeth and got some ice in my veins, working in basically a county hospital with a pretty good knife and gun club. And I came out of that training feeling confident in having done a lot of thoracotomies and seeing even perimortem C-section and a lot of acuity that some people might not have the benefit of seeing in some of their training. But then I came back to live and work in Maine, where I have a great environment to have a family and keep my kids safe and healthy and all those elements that come with being in a less urban, less violent space. And with that, some of the exposure, the skills, again, kind of steely confidence, I found that it started to wane. And I was actually the kind of poster child or reason for SimKit came out of a case where I was working in a remote access hospital. I was working far away from where I live and do my day to day. And we had a patient who, in their middle years of their life, was going through a difficult time, was developing suicidal ideation, and then one night decided to cover herself in gasoline and self-ignite and came into this remote access hospital. And I was a few years out of training, and it was only my second or third shift with this group. And all of the things that would lead one to have challenges in operating kind of at their highest efficiency and providing the highest quality care. And, a lot of oral burns in this patient, attempted an airway, able to get a bougie through what was a very small aperture of really edematous, burned vocal cords, and had to proceed to go do a cricothyrotomy in, again, a really small hospital that I didn't know that well. And while the case itself went fine, went well, I'd say, it was just not as smooth, not as confident, not as clear as I would want for myself. And so from there, I said, all right, I got to get back on it. I got to make sure that my skills in these rare procedures are kept up, and started doing a little bit of basement scientist work, making models for myself to train in them, and realize, okay, Craig's one, but lateral canthotomy is another, and the list grows and grows. And as I built these for me, I recognize that this is not an isolated Jason problem. If you can get into a sim center, that's great. Spend the time, you spend the money, you get there and you do it, and it's kind of a one-off training. But the space repetition really is the part that for me was lacking. And so once I built this for myself, I recognized that, hey, this is probably beneficial for other people like me. And there's a lot of me's out there. And so we decided to start trying to see if people would be interested in getting spaced repetition simulation training delivered to them.
That's great. I think this certainly resonates with me because I've been in the situation where there's something I haven't done in quite a while, and I wish I had done it more frequently. And many of those manual skills, even something as simple as intubation. I mean, that's a skill that is a manual skill, and getting your hands to do the right things at the right time is much easier if you do it over and over again. That's why doing it in a lab on a mannequin, even if the equipment changes, you get new equipment, you use that equipment and practice it a bit,
Yeah.
then you're comfortable. For the non-medical people who may be listening, you're talking about cricothyrotomy, which is the procedure to get an airway into somebody's throat when you can't get an airway into somebody's mouth. Many of you have seen this on television or in
Very
movies, probably.
dramatized. The pen, the
Right,
ballpoint
exactly.
pen through the neck, that type of thing.
I'll show my age. There's a famous episode of MASH where Radar Rowley does it in the back of a Jeep at some point. And lateral canthotomy, sight-saving potential procedure around the eye that we've all learned how to do, but many of us may not have ever done in practice. So, how has this developed from a Jason's idea in his basement
Mhm.
to thinking, you know what, some other people might need this, to growing it as a business now?
Yeah. Yeah, it's been a multi-year process. And it was an interesting bit of feedback. I was doing some leadership training through my hospital system, and one point was to get the opinions of people you know and love about you and how you think and operate. And my father-in-law filled out the survey, and he mentioned, they asked for areas where you can improve yourself and your operation, your thought processes, et cetera. And I think it's pretty telling in being an entrepreneur. He mentioned that I will sometimes jump first and then see if there's water in terms of getting things going. And I think, there was almost a happy accident in that for SimKit for me. In I didn't dive in knowing what this was going to be and what it was going to take in terms of commitment and energy and love, blood, sweat, tears. And it kind of grew over time. I started with the idea. I started to look into what entrepreneurship is like in my area. From there, I, found an entrepreneurial network and even like you can call it a crash course, a longitudinal curriculum over multiple weeks and months where you learn a lot about entrepreneurism. And that really started the snowball rolling downhill for me to sort of take. And I know there's probably many listeners out there that have this is a cool idea. I'd love to consider maybe getting it off the ground. And that first push downhill is sometimes the hardest. And like I said, it wasn't necessarily a super intentional thing, but as it gained steam through, it's the main Center for Entrepreneurs Top Gun program that I did. It started to grow, and I started to have tasks assigned to me about like, what is your total addressable market? What is your patient or your customer's pain point? All these things started really developing it further for me and really springboarded me into creating this product. And it is complex in its own right. We're sending a box every month for 12 months out, and it has a mixture of medical equipment and simulation models, and they all have to be produced and packaged and shipped. And so that complexity just kind of grew and built and smoothed out as I learned what entrepreneurism is as a clinician and physician, and added sort of recognition of my own initially unknowns, and then finding, okay, this is something I'm not as good at. I need to fill in my space with my team to address all these problems as they come up. So it's been a slow, steady growth process for me. But now, yeah, we're fully operational. We have about a year under our belt of sending out kits to providers, not only in the US, but other parts of the world. And it's just been a trial by fire process, finding the areas of weakness and filling them in as we go.
When you talk to entrepreneurs, whether they're in medicine or not, you hear similar stories of slow, steady bumps along the way. I'm sure there are multiple things that have happened along the way that you didn't expect that slowed you down and got in the way, and you figured out a way around.
Mhm.
And I think people maybe think it's easier than it really is. And many of these ideas fail, but in
Yes.
fact, you're now operating as a company. So beyond, and I'm sure you have a list now, and you have a website, which we'll talk about, and
Mhm.
you can find out more about what Jason and his team do. But what are the big procedures that you're teaching use that your materials are being used for now? You're not doing the teaching, but people are kind of teaching themselves with the materials.
Yeah, so we've orchestrated it so that there's a learning management system, LMS, that does kind of hold people's hand through the educational process, just to give that consistency and make sure that it's generally a pretty, uniform shared experience as people go through the curriculum. But in seeing what my areas of challenge were and the pain point of myself, which I think again we all share, it was really those halo, the high acuity, low occurrence procedures, right? We all probably, reduce joints or tap joints relatively commonly. And if you haven't in a while, you have the opportunity to take a look at Roberts and Hedges or refresh your memory and then go and do that. But when it comes to these time contingent procedures where you really shouldn't be scrambling to find a YouTube video, or you should just be really ready to go. Those are the ones that we've targeted, trying to get people confident, trying to avoid that procedural avoidance that is really common, I think, in this space when we're not really, we haven't dusted off the cobwebs. We're not really ready to go in real time. So what we've focused on or focusing on in our first year curriculum is cricothyrotomy, lateral canthotomy, which we mentioned, tube thoracostomy, and gastroesophageal balloon. So your Blakemore, your Linton, your Minnesota. I found those as the ones that are probably the most intimidating for people and have that really strong line in the sand that you just can't put time behind you. People get sicker and you're getting closer to code or loss of vision, and you just need to be ready to go. So that's our first year curriculum. And Right now, we're building out for year 2, which will include central line access combined with transvenous pacing, pericardiocentesis, and cranial burr hole. And we have a long list. We intend to grow further and further from there because there's plenty of procedures that we want to address and get people training in their environment for.
That's a great list. And I think it's hopefully as people hear this, you'll probably get even more ideas. I'm sure you get contacted
All the
almost
time.
daily on by email, by LinkedIn, by whatever method of, I had trouble with this procedure. Can you build one of these?
Mhm.
And then you've got to decide where you're going to put your resources to build those out. And is it just one person who had trouble with the procedure, or is this a pattern? And how do you go about doing the market research and the analysis to figure out what's next?
Yeah, so when we first started, we did both quantitative and qualitative customer discovery work. So we did a survey through, social media networks to sort of ask people how they're training, what they're training on, what they would like for that, what are their barriers to keeping up skills. And then we did individual interviews with providers to get some of that qualitative work to sort of see when you need to brush up on something, where are you going? How are you getting yourself ready to do a procedure that you haven't done in some time? And that kind of comes back to our general belief that, your patients deserve better than YouTube kind of approach. You want them to have a trusted resource that is up to date, that is physician created. And so that's been an area that we are focusing. And in both those areas of customer discovery, we've created a list of these procedures, and we've organized and structured them in a release uh, program or timeline that we think is appropriate. And we continue to get feedback and make adjustments in real time as we go to conferences and hear people's stories. We start developing relationships with other organizations that are trying to, conquer a problem in terms of, neonatal resuscitation or things along those lines. And so it's fluid but structured currently, and we continue to get both user feedback and potential, customer, future customer feedback about what they want to see and what they want to learn.
Yeah, this reminds me of a teaching method. Many of us trained and sometimes work in big urban or suburban places, maybe like Temple or maybe otherwise, where there are lots of people around and one gets lots of practice. And I think as we think through this, particularly if you're someone who works in a big place with lots of resources with residents,
Yes.
as you're discussing doing these things, you can say, okay, do it in the middle of rural Maine when you're by yourself in a snowstorm.
Yeah.
And that suddenly puts a different spin on get this procedure done, get this resuscitation done, get this reduction done. And that's the reality of much of the country, which I think you've experienced and now are helping with.
Yeah. Thank you. I agree that putting that spin on it opens people's eyes, probably changes their degree of confidence. It is easier to be like, yeah, I could watch a resident float a pacer and, correct them where they might make mistakes. But then like, okay, well, do this yourself here without those people, without the cardiologist over your shoulder or the EP lab ready to go. And that changes things. It changes your threshold. They talk in medical education about overlearning and getting to a degree of competence that is well above your expected for your specialty or level of training, and how that can increase the durability of your maintained competence. And so we talk a bit about that. And I think it's an important element to make sure that you're ready for the most extreme version of where you might need to operate and perform.
Which does happen occasionally. I think from popular culture, I think people think these things happen during every shift. We all know they don't.
Right.
But when they do, you don't have a lot of time to figure it out. And so I think that's a reality that we'd like to get the public to know more about. Another reality that we are working on in partnership with our M-Centric Foundation is wellness,
Mm,
and burnout within the emergency medicine community. You, as a practicing emergency physician, you have seen and probably experienced a version of this also, but
yeah.
specific to SimKit, I can imagine that more comfort in stressful situations can help a provider maybe stay willing to practice and I hadn't heard the term overlearning, but being more comfortable in the space and not worrying that they're going to miss something. Is that something you're finding in feedback?
Yeah, I'll say that that's something we're hoping to find. We don't have enough years under our belt or structure in that feedback to get that data point, but I'm hopeful for it, and I believe that it probably exists at least in some degree in what we do and teach. And when we talk about going into the business side of it a little bit, you talk about your early adopters or your different customer groups, and I've always thought of us as that sort of the two sides of the spectrum of practicing docs. There's people like myself when I was, a few years out and had to do that crike and realized my skills were waiting. So early career people that want to keep up their skills and aren't getting into the sim lab with residency, once a month. And then I also think there's those kind of mid to late career physicians who are also recognizing that it's been a decade since I've had to float a pacer, and I don't want to, hang up the stethoscope just yet, and want to continue to provide care. And those individuals are a really important group as well. And so, excuse me. And so I think we talked very briefly about this idea of procedural avoidance, and I what we're trying to address as a pain point in that is when you're walking into shift and you're thinking, I hope I don't have to do this today, or you see a chief complain of bradycardia, and you're like, oh God, I'm gonna maybe try to avoid signing up for that one because I really don't know how to do a pacer. Um, that's affects us, right? It affects our confidence, it affects our sense of well-being and the quality of care we provide. And if you come into that shift and you're like, I'm ready, I've practiced my Blakemore, I've done my Craig training in X, Y, and Z, you're going to have a better sense of well-being, and I believe it'll lead to an avoidance of burnout and a continued sense of quality of care that people are providing. And we do hope to be able to generate that data, as we grow.
And we certainly hope to see that. It certainly makes sense. And even if people don't admit it, they probably do have some level of procedural avoidance. And, it's all well and good to say, I'm not going to pick up that bradycardic patient, except when you're the only person in a department, you're picking up that bradycardic patient.
Yes.
Well, thank you very much. You have a growing business. You exhibit at conferences, and people can find you by Googling your name.
Mhm.
But how can we find you at SimKit? And SimKit is SIMKIT.
Yep. Yeah, the easiest way, if you put that into Google, you'll find us. But our website is SimKit, SIMKIT.co. We're on LinkedIn in the same vein, Twitter, Instagram. We'll have the handles for you available with this podcast, and feel free to reach out to me individually as well. I'm a physician. I'm in the same space. I want to answer people's questions and see if we can help them in any way we can. And that doesn't necessarily mean through our product, but just getting confident and maintaining skills and procedures. Excuse me. And so, yeah, my email, jason.hine@simkit.co, that is open to and available to anyone listening or anyone that wants to talk about what we're trying to address and continuing to practice high quality care in emergency medicine.
Great. Thank you for that. And hopefully this will generate some contacts for you and improvements in what you do because you're trying to improve what we're all doing. So thank you for that. So Dr. Jason Hine, thank you very much for joining us today and sharing your perspectives and experience.
Hotel, thank you so much for having me. It's been a pleasure.
And thank you for joining us in this installment of our M-Centric podcast series, The Shift Report. And special thanks to Dr. Jason Hine for sharing his important insights. For more content, networking, and innovation in the world of emergency medicine, please visit mcentric.org.